to the blood moving like this. Now the issue is, I'm also gonna hear a murmur in this case because blood is moving from left ventricle to left atria. Now listen to the words very carefully, guys. The blood is leaking from LV to LA, but it is very minuscule amount of blood. It might be only 0.5 ml blood, it might be only 1 ml blood, because the volume of blood at the moment is very less. The murmur may not be heard initially. But all this blood that is going from LV to LA, that's the critical point. All the blood that is going from LV to LA ultimately has to come back also, no? But there's venous return coming via the pulmonary circuit into the left atria, right? The blood is oxygenated via the lungs. Now the venous return to the left side will be met with this blood that is leaking from LV to LA. So the combination of this blood, that is extra blood. Why I'm saying extra? Because venous return is also coming, and this blood from LV to LA is also reached in the LA. So LA of this patient is dilated and is having more blood than normal. All this blood will flow back into the left ventricle and will create a flow murmur. I repeat the fact once again, the murmur which will be heard in this case will be a flow murmur. Why I'm speaking about the word flow murmur is because the blood leaked from LV to LA. It will cause dilatation of LA. Now it's going to be met with the venous return, and the combination of this increased blood will come back. So because more blood has to travel through the valve leaflets, it will cause more separation of the valve leaflets, and it can actually contribute to turbulence also. The flow murmur that I'm talking about here, and I've been so descriptive, guys, is the most important statement that I'm making for the second slide for this discussion. Kerry-Coombs murmur, oft asked, characteristic murmur of rheumatic etiology is, it is going to be answered by you as a Kerry-Coombs murmur. Then he can also ask you about the timing. So if he says what is the timing, then in Harrison, Kerry-Coombs murmur is given as a description of mid-diastolic murmur. The logic is saying is that because maximum blood flow into the ventricles occurs in middle of diastole, so it is a mid-diastolic murmur. In contrast, the word is mid-diastolic murmur. Why? Because the blood is reaching into the ventricles in the middle of diastole. That's where the maximum blood flow into the ventricles is, rapid ventricular filling. But in some books, it is also given as late diastolic murmur, especially from the pediatric domain. Now, how to solve this question? Please remember, suppose in the exam, the usual options are early diastolic and mid diastolic, because two options will be systolic. Two options will be systolic, like ejection systolic, pansystolic. Two options will be diastolic. So majority of MCQs, you will notice it will be written early diastolic and mid diastolic. So the answer would be given as mid diastolic. That is what Harrison is saying. But suppose he wants to make it more technical. He says early diastolic, mid diastolic, late diastolic. So for this highly technical question, then the answer will change towards a late diastolic murmur. I want to resolve the controversy here, guys. See, I could have mentioned only one of them and I could have moved on. I've tried to make you aware of this controversy from medicine versus pediatrics. Harrison mentions mid-diastolic, some pediatric books mention delayed diastolic murmur. The controversy can be solved like this. If it's asking you to select between early versus mid, answer is mid-diastolic, as is mentioned in Harrison. I quoted it. If it is going to be early, mid, late, then it's going to be late diastolic murmur. And well, why should I wait for this murmur to actually appear if it's going to be documented early? That is what I started the discussion with. If I can pick this lesion early in the form of valvulitis, then the diagnosis of subclinical carditis is sufficient for diagnosis of this condition. At this junction, I also want to say that he has subdivided the discussion of rheumatic fever into low endemicity versus high endemicity. So I'll just go back to my previous slide to add these details with respect to modified Jones criteria. The meaning of the word low endemicity, though this is more of PSM domain, but one should be clear about the values here, is less than 2 cases detected per 100,000. The denominator is obviously to be listened with care. It is less than 100,000 cases of school age population. The denominator, I repeat once again, incorporates mainly school age population. Now, there is an alternative definition for it, which is the reason why I'm highlighting it. In lot of books or notes, you will notice it is written as less than 1. So lot of guys send me this query, sir, you said less than 2. In XYZ notes, it is written less than 1. That there is a difference in the denominator, guys. In some books, it is written less than 1 case per every 1,000 cases. But in this particular case, they're not taking only school age children. They are taking all age population. I want to highlight this disparity once again. Meaning of the word low endemicity is less than 2 / less than 1. If it is given as less than 2, it is going to be 100,000 cases of school age population. If it's going to be less than 1, it's all age population. So, I mean, anything value, it can be either of the two values given in the question, and you have to be aware of both of these. Otherwise, the disparity usually comes is, sir, you said 2, somebody else said 1, vice versa. So, I've just tried to clear off that particular part. As I've highlighted, echocardiography has been included in the diagnostic criteria of rheumatic fever for subclinical carditis, and then there's a clinical carditis component that would also come up. Now, assuming the fact that the case was not diagnosed on time, then valvular lesion of MS will occur, and there would be a characteristic murmur that can be given in the question, that is mid-diastolic murmur with a pre-systolic accentuation. Why I highlighted that? Because I taught you Kericum's murmur is a flow murmur. It's a plain mid-diastolic murmur. If he adds the word pre-systolic accentuation, you can go through the murmur section. I've spoken about it. If he adds the word pre-systolic accentuation, that means mitral stenosis has already developed. Obviously, there will be supportive evidence also given in the question, like he might talk about a loud opening snap. He might talk about a loud S1 and then even a loud P2 due to pulmonary artery hypertension. But I just want you to be careful, because when you read the word mid-diastolic, there can be error of judgment. You might answer it as mitral stenosis. You might answer this as Kericum's murmur. The pre-systolic accentuation word should be written. In pediatric age group, if it is MR, mitral regurgitation, then there's going to be pansystolic murmur with a uniform intensity all through the duration of systole with a soft S1 present. He can also quiz you regarding management of this rheumatic heart disease patient with severe mitral stenosis. If the orifice area is less than 1.5 square centimeter, normal is 4 to 6, then the patient will be requiring a percutaneous mitral balloon valvotomy to ease off all the back pressure changes. But if the same patient will not get treatment done, and unfortunately there is a calcification developing in the valve, in those circumstances you will not be deploying or rather a balloon. Why? Because the moment you deploy the balloon, guys, this valve will break into pieces, like a cookie will break into pieces, or a cake will crumble into pieces. So you will be forced to deploy a prosthetic valve in the patient. In contrast, if he says what is the treatment for mitral regurgitation, which has a pansystolic murmur, we will try to repair, because there's going to be damage to the papillary muscles, there's going to be damage sustained by the quadrate and DNA, so valvuloplasty will be done in the patient. These are additional aspects that can be written as a sequelae or manifestations of endocarditis in a patient, and most of the time in the exam, the examiner is interested regarding the endocarditis component, so I spoke a little more about it. We come to the second major criteria. At the moment I've discussed only one, the carditis component. I'm now going to describe the arthritis component of the disease. Why? Because the antibodies are going to attack the same connective tissue component. Arthritis is also a early feature of the disease. What I imply by early feature is that if a child with recurrent sore throats will develop rheumatic arthritis, it can develop as early as within 2 weeks of these recurrent sore throats. Now let us see what the parents have to say. They said, sir, this child woke up in the morning, was crying a lot, and he was walking with a limp. So the mother noticed that the child is walking with a limp because he's having an ankle joint swelling. When this child is trying to walk, because of the pain component, he may not be able to go for defecation, he may not be able to take a bath, so the mother had to help him across. Subsequently, after a few days, the swelling of the ankle joint might actually reduce or disappear, and the swelling of the knee joint will appear. And then after a few days, the swelling of the knee joint will disappear. Maybe the swelling of the elbow joint might appear. And it is not that only left ankle, left knee, left elbow might be involved. It could be left ankle joint and right knee joint, and then maybe again a left elbow joint as well. I mean, there's no pattern per se. Any joint can get involved, and the arthritis is jumping from one large joint to another. So because of this jumping character, we are going to call it a migratory polyarthritis. I'm not saying that all joints are involved simultaneously. I'm saying one after the other. Most of these patients, because of the migratory polyarthritis component, they would be lost of disability and the child will not be able to walk. So your job as a physician will be to start this child on aspirin. If aspirin is not working, you might even have to use naproxen in the patient. Normally we use naproxen like for severe pain situations like migraine. But here aspirin and naproxen have been found to be highly effective. With aspirin, they love to talk about this side effect, that is Ray's syndrome. Now, please appreciate my next statement very carefully. It is not alone aspirin which is the villain here. Because if that was the case, then everybody taking aspirin like for chronic stable angina or for cardiac causes would also develop Ray's syndrome. Whenever you are having a combination of aspirin administered when a person is having a viral infection like varicella zoster, a person was given aspirin while he was suffering from, let me say, influenza B infection, the combo of the two is the one that causes damage to the liver and causes Ray's syndrome manifestations. The presentation will be just like hepatic encephalopathy, but there won't be any jaundice. Repeat the fact once again. SGOT, SGPT will be going through the roof. Features of hepatic encephalopathy will develop. Ammonia intoxication will develop because of damage to the liver of the patient. But at the same time, jaundice is not found in Ray's syndrome. That's anyway a concept that I want you to remember, that it is an icteric presentation. Ray's serum bilirubin is usually not grossly elevated. Now, the joint involvement will definitely cause problem for the patient, and lots of time he can mix up this information with that of rheumatoid arthritis as well. In some questions, instead of mixing up the information, he will also have the flexibility of talking about low endemic zone versus a high endemic zone. Low endemic zone can be, for example, America, where obviously due to good hygiene, sore throats will be lesser, so the possibility of arthritis component or per se rheumatic fever will also be less. He says for low endemicity area like America, you have to demonstrate multiple joint involvement one after the other. So migratory polyarthritis has to be there. But for something like India, where the disease is relatively common, he says, why do you want to wait for one joint to be involved, the next joint to be involved, and the next joint to be involved, and let the child suffer over these days and then say, okay, you have rheumatic arthritis. He says if the child is having even a monoarthritis, I repeat the fact once again, in a high endemic area like India, because of the high incidence of the disease, I don't want to wait for multiple joint involvement to occur over a couple of days, causing disability, distress on the part of the parents. He says if you document a monoarthritis component, it's more than sufficient. Obviously, in a high endemic area, if migratory polyarthritis is already present in the history, no problems with this. But as I've highlighted, our objective as a doctor is always to go for early diagnosis. So I would not like to wait for multiple joint involvement to occur in a patient. And then he has included another term here, polyarthralgia. Now, this is obviously to be taken with a lot of, I would say, caution, because you see, polyarthralgia means pain, not inflammation, means pain in the various joints. So other differential diagnosis should also be considered. If suppose a child is having fever with pain in the joints, it could be chikungunya also. Even in COVID-19, you will read about people and children complaining of pain with fever in the joints, right? So the point is, polyarthralgia is something which I just put a star mark to highlight. It should be interpreted with caution because all other illnesses have to be ruled out. But these are terms which are added in the literature. The ones that are put a star mark are must know for you. Why? Because earlier when I was a student, all we used to read was migratory polyarthritis over. But now monoarthritis and polyarthralgia are also written with respect to especially a high endemicity area, like for example India. In America, obviously the standard presentation has to be there because the disease incidence is relatively lower. So this minor difference should be definitely remembered by you, and that's an add-on. Additional fact that I'll use this opportunity to actually speak before, though the topic is covered in the rheumatology section, but I'm getting this golden opportunity to compare the two diseases before you side on. I'm gonna describe rheumatic arthritis versus rheumatoid. Well, the first difference is rheumatoid is gonna be usually a young female, maybe in her 20s. She's complaining of morning stiffness. She says, I have pain in my hands in the morning. I can't even hold a toothbrush. But then gradually when I start brushing my teeth or moving around, then the pain begins to reduce. When I asked her, ma'am, can you point where the pain is? She's pointing to the small joints of the hand. That's going to be PIP, MCP and the wrist. And if she's pointing to the left wrist joint, she will obviously point to the right wrist joint also, bilaterally symmetrical. But when it comes to rheumatic arthritis, it will mostly be a child. Can be a person, but will be relatively a younger age group. When I talk about adult, it will be relatively younger. In this case, it will be large joint involvement. And this large joint involvement will be jumping from one joint to another and will not be bilaterally symmetrical. It will be rather random. I mean, like today it is elbow joint. Maybe after 2 days, it could be the opposite side ankle joint getting involved in the patient. For the left hand side, that is rheumatoid, the antibody test that we do is called as anti-CCP, cyclic citrulline peptide antibody. Whereas for rheumatic arthritis, the supplemental evidence would be ASO titer, because we are gonna have evidence of bacterial infection in the body. So ASO titer will definitely be elevated. On the left hand side, the drugs used would be like methotrexate or leflunomide, or even in the discussion of rheumatoid arthritis, I've talked about tofacitinib. But on the right hand side, I have mainly talked about usage of aspirin and even naproxen in the patient. So there is absolutely no reason why rheumatoid versus rheumatic can ever be missed. And I've just done a quick comparison in this case. And rheumatoid anyway, guys, I mean, one of the important differences that will now come up will be rheumatoid will always be an example of erosive arthritis, no? Because you always in rheumatoid arthritis will be having either a Boutonniere deformity or a swan neck deformity, Z-line deformities. I mean, rheumatoid per se will always cause deformities in the hand, whereas the right hand side rheumatic is an example of non-erosive arthritis. The points to be remembered is